Hi, welcome to our annual Environmental Health Day webinar. This year's topic is what's new since last year in the world of multiple chemical sensitivities. The World Health Organization tells us that chronic non-communicable diseases are the leading cause for morbidity and mortality around the world. There are 4 risk factors: tobacco use, harmful use of alcohol, unhealthy diets, and physical inactivity. But now they tell us that air pollution is also a major risk factor for developing chronic disease. Given that chronic disease is related to pollution, it's not a surprise that the closer you live to a major roadway, the more likely you are to get these diseases. So where do you live and work? Proximity in the studies is anywhere from 50 to 500 meters. And a major row is maybe 10,000 cars per day. But look at these diseases that you're more likely to get or are more likely to be worse the closer you live to a major roadway. Allergies, asthma, respiratory infections, cardiovascular disease, diabetes, fragmented sleep, decreased cognitive function, and reduced kidney function. And unfortunately, the closer you live to major roadways, the more likely you are to die from all causes, including strokes and other circulatory diseases of the brain and the heart, chronic lung disease, lung cancer, and so on. Making things even worse is the fact that it's not just the air that we breathe that gives us exposures to various pollutants, but we eat them, we wear them on our body, etc., so that the average person has up to 200 chemicals stored in their body. Look at this list: fire retardants, stain repellents, pesticides, industrial chemicals, plastics, plasticizers, persistent organic pollutants, which are chemicals which just don't break down, even though some of them have been banned for more than 25 years. Cosmetics, heavy metals, and second and even third-hand smoke, which is smoke that exists on the skin and hair and clothing of people who smoke. How well we can detoxify or clear out these chemicals that accumulate in our body is dependent on our genetics. If we're not very good at detoxifying, the levels of chemicals in our body will tend to accumulate higher, and as a result, we are more at risk for these diseases: cardiovascular disease, asthma, chronic kidney disease, diabetes, arthritis, liver disease, neurodegenerative disorders like Alzheimer's and Parkinson's, male infertility. For pregnant women, there's a risk for the baby being born with spina bifida, cleft lip, or cleft palate, and there's also risk for various cancers. If we don't detoxify well, there's damage to cells, which we can measure. This could be because our genotype is abnormal, as I've mentioned. It could be because we have too much chemical exposure and there's too much of a burden on our detoxification system, which can't handle it. Or our system is functioning in an inferior fashion because of poor nutritional support. But as a result, we get an accumulation of toxic chemicals inside cells called free radicals, or oxidants, or reactive oxidative species, and they outweigh the effect of the antioxidants on our detoxification system, and as a result, we get something which we can measure in research labs called oxidative stress. This leads to damage to cells, which leads to a dysfunction of cells causing unwellness, or even tissue damage, organ dysfunction, and systemic inflammation. Oxidative stress can affect any organ system. When it affects the cardiovascular system, we'll see more arteriosclerosis, dysfunction of the lining of the blood vessels, and high blood pressure. When the brain is involved, we're more likely to see neurodegeneration. So we see conditions such as Parkinson's and Alzheimer's disease. In kids, we're more likely to see neurodevelopmental disorders like autism. We see chronic migraine, and we see chronic pain. When the immune system is involved, allergies and autoimmune diseases are more likely to occur. Autoimmune diseases are diseases when our immune system actually attacks our own systems, and we see systemic inflammation. When the hormone system is involved, we'll see diabetes, obesity, thyroid disease, and changes in pregnancy outcomes. With musculoskeletal system, we will see rheumatoid arthritis and other rheumatic diseases and degenerative joint diseases. The gastrointestinal system can be involved or more likely to develop non-alcoholic fatty liver disease and inflammatory bowel disease. If the skin is involved, we'll see eczema and psoriasis. Chronic kidney disease can occur as well from oxidative stress, and we're seeing environmental linked conditions are more likely to occur, including multiple chemical sensitivities, myalgic encephalomyelitis, chronic fatigue syndrome, and fibromyalgia. These are all the effects that we can get from oxidative stress. So these are the reasons why we refer to people with multiple chemical sensitivities as canaries. They can feel the effects of the exposures while the rest of us can't. But those changes inside cells are still going on. It just depends on how it comes out. So let's refresh our memory on what exactly is multiple chemical sensitivity. These are the case criteria to diagnose it. The symptoms are reproducible with repeated exposure. It's chronic, it doesn't go away, and it's low levels of exposures, lower than previously tolerated or tolerated by other healthy people. And the symptoms improve or actually resolve when you get away from the triggering exposures. What's interesting as well is that these responses occur to multiple chemically unrelated substances, and they involve multiple organ systems. People with MCS know which chemicals bother them. They are multiple and everywhere. But for those of you who aren't familiar, look at this list. Fragrances, paints, glues, products from renovation, cleaning products, carpets, building materials, furnishings, pesticides, vehicle exhaust, and many other chemicals as well. Why did people with MCS become sensitive in the first place? Well, one reason is that they're more likely to be poor detoxifiers genetically. And if they do not detoxify well for whatever reason, they get damage to cells. And in their case, the neurons become sensitized. In order to explain to you why people with chemical sensitivity are sensitive, I need to explain to you first why hot peppers actually burn. It's because they stimulate sensors in the nervous system to register the message of intense heat, which they can do even if they're very cold, because you just took it out of the fridge or even the freezer. The chemical in hot peppers, which stimulates that sensation of heat, is called capsaicin. It's used in pepper sprays, which we use to keep away bears in the forest or quell student riots. This effect of capsaicin is well understood in the world of medical research. When we inhale it, it makes us cough, so it's been used in studies of cough and cough medicines worldwide. It stimulates sensitive sensors in the bronchial tubes, and these sensors are also sensitive to chemicals. And MCS patients are hypersensitive to the inhalation of capsaicin. This chemical makes them react at much lower levels than it does to normal healthy people. When we do studies of chemically sensitive patients using the capsaicin inhalation challenge, we can demonstrate sensitivity. And in fact, it's been demonstrated in 17 different studies, and none of the studies were negative. There are other studies on MCS which show biological abnormalities as well. For example, functional brain scans. A functional brain scan is a scan which measures changes in function. In other words, if we ask a particular area of the brain to be more active, it should show a different image on the scan compared to inactive areas. When we take these brain scans at rest, in other words, in patients with MCS without chemical exposure, the results are controversial. Some studies show that the brain scan is abnormal and others don't. However, when we do a functional brain scan after a chemical challenge, it is clear that MCS patients process odors differently when compared to controls, and there are 6 studies to demonstrate this. There's also an abnormal hearing reflex in patients with MCS. So they are noise sensitive, or they have speech and noise disturbances. What this means is that, for example, when you're in a crowded restaurant and you're listening to the person across the table from you, a normal hearing person is able to block out the background noise from the rest of the restaurant and focus on who they're listening to, whereas patients with MCS have lost or have a diminished reflex in this area and have more difficulty detecting speech and noise. There's also studies on the metabolome. The metabolome is a very complicated, new, sophisticated way of measuring thousands of normal chemicals that are natural within the body as part of the body's metabolism. It's clear also from the literature that various chronic diseases have abnormal and different and unique metabolomes, and so does MCS. Unfortunately, there's a lack of education in medical schools. Students are not being taught how to take an environmental exposure history, and no interest is generated. This is a picture that I took of family practice residents considering an extra year of postgraduate training. They were interested in emergency medicine or sports medicine, etc., but none of them were interested in environmental medicine. In fact, there is no postgraduate training in environmental medicine in any specialty. They do not learn how to manage the impact of chemical pollutants on any of their chronic diseases in which they're interested. So what's new in the field of environmental medicine since last year? Well, there are studies in long-term follow-up, prevalence, regarding the controversy of environmental medicine. There was a task force that was set up by the Ontario Ministry of Health and Long-Term Care, which finished their final report at the end of 2018. There are studies on something called central sensitization, which I'll share with you, as well as more studies on the effects of indoor air. First of all, there was a long-term follow-up study performed in Japan in which they surveyed patients diagnosed with multiple chemical sensitivities 10 years ago. It was noted that in 2003 in Japan, they had mandatory restrictions on the use of construction materials to try and decrease off-gassing, and they also put more emphasis on the installation of ventilation equipment in new buildings. And as a result, there's less association of an onset of MCS with new construction. On the other hand, there's been sharp increases in sales of scented products, most notably fabric softeners, and as a result, scents have increased as a trigger in MCS. They've also noted that MCS is becoming more severe in the Japanese patients. For example, patients with MCS have a high prevalence of allergic diseases like asthma and eczema, but in the last 10 years, these diseases have more than doubled in the MCS patients. And this is significant because unemployment is associated with the severity of MCS. On the other hand, there was a paper published from Japan which showed improvement in 2/3 of the patients. It depends on what you measure. In this case, the improvements were in irritability, fatigue, anxiety, depressed mood, and as a result, less physical symptoms. They attributed this to appropriate physical activity and maintaining a regular lifestyle, including a proper diet and proper sleep. What they noticed as well was that the autonomic perception in situations which provoke anxiety was decreased if the patients improved. The autonomic nervous system is the automatic nervous system which gets involved in the stress response. Heart rate, respiratory rate, changes in the temperature in the skin, etc. Patients were less attentive to these physical responses when they actually started to improve in their symptoms. So you can be somewhat better, just depending on what kind of lifestyle you're able to maintain. What is interesting about this study is that they took a look at the control group and followed them for 5 years as well. 6.7% of them developed MCS, and the onset was associated with their psychosomatic state, in other words, how stressed they were, how many symptoms they had that were unexplainable, as well as eczema. Having eczema was associated with the onset of MCS in this group. What was also associated with the development of MCS was exposure to chemicals from renovations and new carpeting. On the other hand, if they maintained that same regular lifestyle of eating well, sleeping regularly, exercising, etc., this had a very positive effect on not developing the MCS. The term prevalence is used to describe the number of people with any given condition at any point in time. So, there are numerous studies that have been produced over the years trying to identify the prevalence of multiple chemical sensitivities. The problem is how to capture the MCS patients accurately, because there is no biological marker and we're not sure how to do it correctly. These studies are usually done by survey. So, one question to be asked is, do you consider yourself to be allergic or unusually sensitive to everyday chemicals like those in household cleaning products, paints, perfumes, detergents, insect sprays, and things like that? If a person answers yes to that question, they are self-diagnosed with MCS. Then there's the question, has a doctor or healthcare professional ever told you that you have multiple chemical sensitivities? And if the answer is yes, they are doctor diagnosed, even though there is no blood test to prove it. These questions have been asked in numerous studies of prevalence in the US, in Sweden, and in Canada. There are also studies done just regarding self-reported general odor intolerance, or being bothered by chemicals such as perfume, cleaning products, or flower scents. And again, several countries around the world have used this: Australia, Japan, Korea. We're not sure exactly what the prevalence statistics really are. There was a prevalence of MCS study performed in the last year in Australia. 6.5% of the population has been medically diagnosed with MCS. Almost 19% of the population describes some chemical sensitivity, described as being unusually sensitive to everyday chemicals and chemically formulated products. That's really high. Among the people with MCS, almost 92% have sensitivity to fragrances. 78% almost are prevented from access to places because of fragrance products, like restrooms, businesses, workplaces, and public places, especially and notably health facilities. Almost 75% have been diagnosed with asthma or an asthma-like condition. 55% report health effects that they consider potentially disabling. and 52% have lost workdays or a job in the past year due to fragrance product exposure in the workplace. There was also a study reporting the prevalence in Sweden and Finland. Not surprising, they found that women were afflicted with MCS much more commonly than men. And the prevalence rates in general were pretty similar because they're pretty similar to most other countries. However, the people in Finland were more likely to be of lower education and rated their health more poor. They also reported more sensitivity to chemicals in Finland than in Sweden, and to be more sensitive in certain buildings. But comorbidity, that is the ongoing conditions which accompany MCS, were more common in the Finnish sample, such as eczema, migraine, and irritable bowel syndrome. But in the Swedish sample, we saw more post-traumatic stress disorder and chronic fatigue syndrome. The authors made the comment that these findings reflect the heterogeneous nature of MCS. There was also a study published last year regarding the prevalence of MCS in the States, and they found that 12.8% of the population were medically diagnosed with MCS. 71% of those people are asthmatic. 60% of them lost workdays or job in the past year due to illness from fragrances. 26% self-reported chemical sensitivity. And of that group, almost 60% were asthmatic. And when you compare these numbers to the prior U.S. national prevalence studies, in the last 10 years, there's been a 300% increase in diagnosed MCS and a 200% increase in self-reported chemical sensitivities. Just a few months ago, there was a study published looking at the potential for developing MCS if you're born by C-section. Being born by cesarean section means that your exposure to bacteria is different. When you're born vaginally, your exposure is immediate to the bacteria around mom's vagina, around mom's rectum, etc. Whereas when you're born by C-section, you're exposed to bacteria from the skin. And there are several medical conditions which are influenced by the fact that you're born by C-section. So the question is whether or not that environmental change would have an impact on developing MCS. And what they found is that birth by C-section correlates with an increased incidence of MCS. And in fact, those patients are also more likely to have migraine, bronchial asthma, allergic rhinitis, allergies to metals, fibromyalgia, and chronic fatigue syndrome. There's a family history of MCS in these patients. There's a history of agricultural work. They tend to be mouth breathers. They tend to be people who move frequently into new homes, at least within a year of its construction, and they have electromagnetic hypersensitivity. But there's a correlation with birth by C-section. The health of Canadians is monitored every couple of years by the Canadian Community Health Survey. So here's a question. How many patients are there with MCS and its related conditions in comparison to other chronic diseases? You can see clearly from these numbers that more patients have MCS than cancer, than the effects of a stroke or Alzheimer's, etc. And it is even more common to have more than one of these three conditions. The next Canadian Community Health Survey will be conducted in 2020, but unfortunately questions on MCS will not be included. If you want to know why, ask anybody you know at Health Canada or the Public Health Agency of Canada, which made this decision. Or if you want to complain, Call your MP. We don't know why the questions are not being included, but we do know that MCS prevalence has increased over 300% and chemical sensitivity over 200% in the USA. It's probably similar in Canada. Why aren't they asking questions on MCS? So those of you with MCS or in support of a family member with MCS, you probably ask, why is it still considered controversial? Well, according to the science that's published, there's no agreed upon case criteria to diagnose it or define it for research. There's no physiological evidence for sensitivity. In other words, all blood tests, physical exams, etc. are normal. You can't prove sensitivity to chemicals. It's not consistent with what we understand about toxicology, which is that high doses are poisonous. And there's an association with psychiatric illness, which makes it easy to argue that this is a psychiatric condition. The consequences of all this is that patients' needs are still not being met. There's no support for the patients by primary or secondary healthcare providers. There's resistance to accommodation despite the Canadian Human Rights Commission support. There's resistance to claims and benefits with third-party insurance companies because they resist the likelihood of the diagnosis. One reason for the controversy in environmental medicine is that different experts in the field have differences of opinion. This paper was published about 1 year ago, in which semi-structured interviews were used to determine the opinions of various experts in the field in Australia and New Zealand, and to collate the information in order to get some kind of a scientific data collection that would be useful to understand the controversies. They interviewed 16 clinicians, 11 environmental medicine doctors, and 5 occupational health physicians. There is no question that environmental medicine is a divided profession. Environmental medicine doctors are quick to attribute reactions to environmental exposures, whereas occupational health physicians do not think that this is consistent with traditional toxicology, and that most likely the attribution of unexplained symptoms is psychiatric. The assessment of exposures is challenging. How much of an exposure is necessary to cause a reaction? And the information that is obtained clinically is usually the patient's observations and therefore may not be accurate. The environmental exposure history is therefore the most important clinical tool. And this history was developed by environmental medicine physicians and is used consistently with every patient at every visit. It's clear that patients with environmental sensitivities are increasing in number. They have unique characteristics. They're complex to treat, and they rarely regain full health, no matter what your opinion is about the cause or etiology of the condition. And it is also clear that educational and clinical resources for these patients and the doctors are lacking. Thus, we have 2 distinct groups of physicians: the environmental medicine practitioners and the occupational health physicians. The environmental medicine practitioners work in private practice. Occupational health physicians tend to work for companies. They tend to assess and monitor workers' health. They're advisors in government departments, and they work for an agreed fee to conduct medical legal work, to assess causation or disability, working for insurance companies or workers' compensation. And thus, one of the differences in perspective is based on the nature of the employment of the physician. It's whether or not the clinical care provided is patient or corporate centered. So let's look at the difference between the two groups of doctors and what kind of patients they're actually seeing. Environmental medicine patients are much more often middle-aged women as opposed to men, whereas in occupational health, the patients are more likely to be adult men. In environmental medicine, the patients arrive with chronic, complicated, ill-defined conditions. They have multiple symptoms characterized by long-term fatigue, such as is seen with chronic fatigue syndrome and fibromyalgia. They have allergies. They're intolerant to many things, foods, drugs, etc. They have digestive disorders, and they have chronic autoimmune, metabolic, and or neurological conditions. In occupational medicine, they're more likely to see musculoskeletal injuries, or they see disorders arising from occupational exposures to things like heavy metals, asbestos, coal dust, beryllium, pesticides, and solvents such as benzene, diesel, and isocyanates. The toxicants of concern for occupational health physicians are usually unusually high exposures, either acutely or chronically, which arise in the workplace or from hobbies. Where the environmental medicine physician is more concerned with long-term everyday exposures to low-level toxicants found in the indoor air in the workplace and home, or in food or personal care products, and the combined effects of all these exposures. Another difference of opinion between these two groups of doctors is their perspective on nutrition. Occupational health physicians consider nutrition as fringe medicine. They do not think that food is an important source of toxicant exposure, except perhaps for mercury in fish or pesticides in fruit. On the other hand, environmental medicine physicians think that food can be an important source of toxicant exposure, such as plastics. Good nutrition is also required to build resistance. We need to support our systems for detoxification with antioxidants. We need good nutrition to enhance cell repair. And we need to focus on reducing obesity. From an environmental perspective, this is because many environmentally linked conditions are more severe if we are overweight or obese. And secondly, the body burden of chemicals, those chemicals stored in the body, is usually most significant in fat. This is where these chemicals are stored. And the fatter you are, the more chemicals you have as part of your own body burden. Another way these groups of physicians differ in opinion is with respect to the assessment of toxicant exposures. We lack clinical guidelines. In other words, even though there are some chemicals that have recognized limits of exposure that are considered otherwise toxic, we do not have guidelines for the majority of chemicals that we're exposed to every day. And in particular, we have no guidelines for the exposures of the soup of chemicals to which we're exposed on a regular basis in real life. There are limitations in the clinical laboratory testing. Patients with chemical sensitivities usually have nothing physically wrong according to physical examination or routine clinical lab testing. So we have a hard time verifying their complaints objectively. Secondly, we do not have any clinical laboratory tests available to measure chemical exposures or their impact. So we have a difficult time establishing a cause and effect relationship from exposures. What medical science does is base it on probabilities. 95% likelihood is the bar set in medicine for one event to cause another. Otherwise, we use the word association. An example could be that obesity is associated with heart disease. You're more likely to get heart disease if you're obese, but it's not necessarily the cause of heart disease. On the other hand, in courts of law, the bar is only 51%. In other words, if it is more likely than not for one event to have caused another, that's enough to accept it in court. But unfortunately, when it comes to medical arguments, the judges and arbitrators are listening to the medical experts who set a very high bar of 95% likelihood. What is agreed upon by all clinicians in environmental medicine is that the exposure history is the most important clinical tool for assessing exposure. However, occupational medicine physicians focus more on occupational exposures from the workplace, whereas environmental medicine physicians are more concerned with traffic-related air pollutants, pesticides, indoor air in the workplace and home, etc. And despite its importance, most clinicians are not formally taught how to take an environmental exposure history. The two groups of physicians do agree that patients with MCS are complex to treat and rarely regain full health. But they have differences in perspective as well with respect to that complexity. Environmental medicine physicians see that the number of patients with MCS appears to be increasing. They think that they are more likely to have gene variations with respect to detoxification. In other words, they aren't genetically as good at detoxifying as healthy people. And they also believe that sensitization to chemicals from repeated exposures is a valid phenomenon. Furthermore, patients with MCS often have comorbid or multimorbid diseases, including chronic fatigue syndrome and fibromyalgia. And these patients are even more difficult to treat due to the fact that they're more severely disabled, they're more complex, and they have a poor tolerance to treatment. The occupational medicine physicians, on the other hand, are more likely to attribute the symptoms to psychological factors. MCS is in your head, and they attribute that to the linear dose-response relationship, which does not explain their symptoms. What, you ask, is a linear dose-response relationship? This is what a dose-response relationship looks like. It's actually a graph where we look at the amount of chemical exposures and its effect on causing symptoms and signs in the person exposed. So we start off with a low dose, and as the dosage of exposure increases, we get to a certain point where there's a threshold and we start to get symptoms and signs. This happens to everybody. It's a toxic exposure. There's a toxic response, and then we have what we call maximum damage. But this point down here, the toxic threshold dosage, is what we look at in traditional toxicology. The dose makes the poison. Everything has a toxic threshold. Both groups of physicians agree on this point, that educational and clinical resources for environmental medicine are lacking. There's no single resource that we recognize as comprehensive or an industry standard. There's no training program recognized either. There are online sources for journals and databases that doctors can refer to, such as Google Scholar or PubMed, and there's local and international conferences, but that's it. In 2016, a task force on environmental health was established with a 3-year mandate. It was established by the Ministry of Health and Long-Term Care in the province of Ontario in Canada. There were 15 members appointed by the minister, and it included expert clinicians, researchers, patients with lived experience or their caregiver, and representatives from various health system organizations around the province. The purpose of this task force was to provide advice on how to overcome the gaps in knowledge, in care, and in attitudes. In July of 2017, the task force submitted their first interim report, in which they identified a number of early concrete steps that they recommended to be taken as soon as possible in order to establish a foundation for effective, patient-centered system of care for people with MCS. They encouraged the government to support a change in the conversation. That is, to increase the understanding and the recognition of MCS as a true biological phenomenon. In particular, recommendation 2.1 was made to develop clinical case definitions and clinical practice guidelines in order to provide standardized, high-quality, patient-centered care for the people with MCS in Ontario. In order to lay the groundwork for a patient-centered system of care, several recommendations were made by the task force. Recommendation 3.1 established detailed clinical care pathways for these patients in order to support the development of an evidence-based system of care. Recommendation 3.2, hospitals should be made safe and accessible for people with MCS, and it should start with mandatory scent-free policies. Recommendation 3.3, long-term care homes should be made safe for people with MCS too. These patients are going to get older, and we don't know how to treat chemical sensitivities to make it go away, and so safe homes need to be provided in long-term care for these patients as well. We need to also increase the number of knowledgeable providers. Recommendation 4.1 was to continue to fund the Enhanced Skills Program for third-year family practice residents in clinical environmental health. Perhaps you recall that picture that I showed you where I was sitting at a desk being ignored by all the second-year family practice residents. We do have a program, a third-year education program, where we've been training residents in family medicine to practice environmental medicine, and it's funded by the Ministry of Health of the Province of Ontario. The next paper to be reviewed was published by Drs. Howard Hu and Cornelia Baines. Dr. Hu was chairman of the task force for the first 2 of his 3 years, and he was also the dean of the School of Public Health at the University of Toronto. It's the largest school of public health in the country. Cornelia Baines is a researcher at the University of Toronto, and she published several papers on MCS at the turn of the century. She looked at the genetics for MCS and was one of the first to describe an abnormality with respect to detoxification. She also published papers which validated the consensus criteria for the diagnosis, which was established in 1999. The paper looked at funding for research on MCS, and it reveals this. There were more than 7,000 references for chronic fatigue syndrome in the medical literature, more than 9,000 for fibromyalgia, but only 320 specific references for multiple chemical sensitivities. In the USA, currently, there's no funded research for multiple chemical sensitivity, and there were several years where no grants were funded as well. In Canada, the research funding for all 3 conditions has been meager to non-existent. There was a 3-year gap from 2012 to 2015 when they funded a combined total of $1.8 million. Compare this to conditions like emphysema or multiple sclerosis or epilepsy. These conditions have lower prevalences, but the Canadian Institute of Health Research provided less than 10% of the funding for MCS, chronic fatigue syndrome, and fibro compared to these 3 conditions. They granted 0 grants for research in multiple chemical sensitivities. Drs. Hu and Baines also looked at stigmatization in multiple chemical sensitivities. They found that the social stigmatization is severe, and as a result, it increases the risk for patients to develop anxiety, depression, and other psychological symptoms that can be mistaken for causes rather than the effect of having the disease themselves. There are legal struggles that often occur regarding causation or regarding avoidance issues, which would require accommodation or support from family members, etc. And it arguably casts a chill on clinicians and scientists. It deters their involvement in clinical care, in research, and in advocacy. doctors and scientists tend to avoid these kinds of controversies. And so Drs. Hu and Baines called for a national effort to increase research directed at all three conditions as distinct entities: MCS, chronic fatigue syndrome, and fibro, which frequently occur together, but we need to also study them together because they frequently occur together. The final report of the task force was submitted to the Ministry of Health and Long-Term Care in Ontario at the end of December 2018. Thus far, the report has not been made public, so I am not allowed to share with you the final recommendations that were made by the task force upon which I sat. The report must be made public. People need to know what's been recommended, and supporters and advocates for those with MCS need to be talking to their provincial members of parliament to make sure that the report does get released and that the ministry acts upon the recommendations that were made by experts. The task force worked with the Centre for Effective Practice to develop consensus-based clinical definitions for chemical sensitivities, as well as chronic fatigue syndrome and fibromyalgia. This center did a literature search for existing case definitions. They selected, recruited, and engaged a panel of experts, and they facilitated a modified Delphi process, which is a commonly used methodology to achieve consensus amongst a group of experts. This panel supported the use of the 1999 Multiple Chemical Sensitivity Consensus Statement, the same diagnostic criteria which was validated by Dr. Cornelia Baines, as mentioned previously. As presented earlier in this webinar, here is the consensus definition for multiple chemical sensitivity. The symptoms are reproducible when the person with MCS has more chemical exposures. The condition is chronic. It doesn't go away. Low levels of exposure, which were tolerated previously and are tolerated by the general healthy population, now result in the manifestations of symptoms. The symptoms do go away when the incitants are removed, and the responses occur to multiple chemically unrelated substances, and the symptoms involve multiple organ systems. The original publication of the consensus definition was in 1999. These 6 criteria are still unrefuted, almost 20 years later, and are all commonly encompassed by research definitions of MCS. So here we are in 2018. The Center for Effective Practice developed an expert panel which supported the use of the 1999 MCS consensus as well. If you can't tolerate a particular medication and you report it to your family doctor or the prescribing physician, it is routinely documented in medical records as, quotes, allergies. And this is despite the lack of evidence for an allergic reaction. So symptoms like headache and nausea, dizziness, fatigue, these are not symptoms of allergy, and the allergic pathway is not involved in these reactions either. Nevertheless, they have come up with this term polyallergy, which they use to describe the presence of any 4 or more documented drug adverse reactions, even if they aren't true allergies. So using this term, a paper was published last year in which the authors used the term polyallergy, or the definition of polyallergy, to represent MCS. What'd they find? Their study demonstrated that polyallergy/MCS may very well signal accompanying psychopathology and/or abnormal illness behavior. So despite the fact that we have had definitions by consensus made by experts available for 20 years, these guys come up with their own definition of MCS and then do research to show that it's a psychiatric illness. In order to understand chemical sensitivities, one needs to understand central sensitization. And this is described as a state in which the central nervous system, the brain, amplifies sensory input. So in other words, what you hear, what you smell, what you feel is amplified, and it's often amplified in an abnormal fashion. There are physical symptoms as a result, although the physical examination and laboratory data are usually normal. So it's termed a functional disorder, or medically unexplained physical symptoms, MUPS. You will see these two terms used repeatedly in the medical literature when they're talking about this term, central sensitization. The difference is that the latter two terms, functional disorder and medically unexplained physical symptoms, implies that there's nothing to be found in these patients, whereas central sensitization implies that there's something going on with the sensory system of the brain. There's a dysfunction in processing of sensory information. Central sensitization has been described as any sensory experience, whether it's painful or not, that results in a greater than anticipated severity, duration, or a larger area than expected. It's disproportionate to any peripheral reason, but it's due to an increased excitation or a reduced inhibition of the nervous system. We see it in chronic pain disorders like fibromyalgia, irritable bowel syndrome when there's pain involved, temporomandibular joint dysfunction, migraine and tension headaches when they're chronic, myofascial pain syndrome, and some chronic pelvic pain disorders such as interstitial cystitis, which is a painful bladder, or primary dysmenorrhea, which involves painful menstruations. We also see it in non-painful conditions such as post-traumatic stress disorder, or restless leg syndrome, or overactive bladder, or chronic fatigue syndrome. And we see it in multiple chemical sensitivities. These syndromes are all known as central sensitization syndromes. The term central sensitization syndromes describes multiple conditions which appear to be unrelated, but they all share the common theme of hypersensitivity to stimulation. They often occur in the same individual. Having one of these disorders is strongly associated with having another. In other words, if you have one, you're more likely to get one of the others. And the more you have, the more likely you are to get even more. This pattern of clustering in the same person is considered a distinguishing characteristic of these syndromes. Having a previous one is the strongest risk marker for getting another one. And it involves the action of those capsaicin-sensitive receptors, also known as TRPV1 receptors. These are the ones that are sensitive to chemicals and are sensitized in MCS. But they're also involved in chronic pain, and they're found to be hypersensitive in irritable bowel syndrome and irritable bladder. So in 2018, 3 papers were published on central sensitization. There are co-occurring symptoms in all of these syndromes: pain, fatigue, mood and cognitive problems, sleep disturbances, and multisensory hypersensitivity, just like in MCS. The patients more often report a previous exposure to psychosocial or physical stressors, just like MCS. There's a higher personal lifetime and family history of pain. Brain scans show changes in the brain gray matter in the brain processing regions, even if pain is not a major player in that particular syndrome. There are neurochemical imbalances and immune system abnormalities. There are increased chemical messengers for inflammation. They're called cytokines. There's one in particular called interleukin 8, but it is often increased in central sensitization syndromes. There was one paper published last year about sick building syndrome. They reported that abnormalities are often found, including inadequate ventilation or increased emissions from furnishing and building materials or moisture and mold in the building structures. The people who complained about the environment in these buildings practice avoidance behavior over 60% of the time. In other words, they left the building or they didn't go to work at all because of the provocation of symptoms that they would experience. Nearly half of the people in these buildings sought medical care. Sick building syndrome was associated with elevated odds for all studied comorbidities. In other words, other conditions occurring as well, such as somatic and psychiatric diseases and functional somatic syndromes. However, the highest odds for a comorbid condition was asthma, at 7 times more likely than in the general population. Sick building syndrome also shares features with other environmental intolerances such as chemical sensitivities and electromagnetic hypersensitivity. The increasing knowledge that we have developed in sick building syndrome suggests that the core of this intolerance in certain buildings is chronic hyperresponsiveness of the individual rather than the exposure itself. Many of you are probably already familiar with fragranced consumer products and what this means. It's defined as products with an added fragrance or scent, and there are multiple sources of fragrance consumer products in your environment, such as air fresheners, deodorizers, cleaning products, laundry supplies, household items, perfumes, personal care products, and items for babies. And there are more than 150 different VOCs which can be emitted from these commonly used products. In the past year, there was a paper published which looked at fragranced baby products. They measured VOCs emitted from 42 common ones and found 228 different VOCs. 43 of these VOCs were classified as potentially hazardous, but only 5% of all the VOCs, or 12% of the potentially hazardous VOCs, were even listed on any product label or any safety data sheet or the website of the producer. Here's what's really important to note. The emissions from green, organic, or naturally fragranced baby products were not significantly different from the regular ones. This paper also demonstrated that 64% of asthmatics report adverse health effects from fragrance products. Other health effects, respiratory problems, 43%, non-asthma symptoms. Migraine headaches, 28% of asthmatics also get migraine headaches provoked. And 28% of the asthmatics reported that they got asthma attacks with exposure. It's not that surprising that asthmatics would be affected by fragrances. They were more likely to experience adverse health effects from just being near somebody wearing a fragrance product, almost half of them. Being in a room clean with scented products. Air fresheners and deodorizers provoke symptoms. And scented laundry products coming from a dryer vent. What does this mean? Well, when you go outside in your neighborhood for a walk, if your neighbor is doing the laundry, there's a good chance that you can smell those laundry products coming out of the vent. 99% of asthmatics are exposed to fragrance products at least once per week, and almost 2/3 of them consider the reactions disabling under the definition of the Americans with Disabilities Act. 1/3 lost work days or a job in the past year due to fragrant product exposure in the workplace. And more than 1/3 of them cannot use a public restroom if it has an air freshener or a deodorizer. And 40% of them would enter a business and then leave as quickly as possible because there's air fresheners or some fragranced product emitted into the air. We also know that pregnant women and the developing fetus are susceptible to pollution. Why do I tell you this? Because it's been demonstrated in the last year that maternal exposure to air pollution during pregnancy is associated with an increased risk of autism spectrum disorder in the unborn child. Mothers with MCS, genetically more likely to be poor detoxifiers. They are 3 times more likely to have a child with autism. And they're 2.3 times more likely to report a child with attention deficit hyperactivity disorder. This paper looks at the combined statistics from 3 national studies performed in the United States, Australia, and the United Kingdom. And it looks at adults with autism and the effect of fragrances. 84% of them report adverse effects from fragrance products. 84% of adults with autism. Respiratory problems, asthma attacks, migraine headaches, and neurological problems. These people are also more likely to experience adverse health effects from being near someone wearing a fragrance product, almost 2/3. Or being in a room cleaned with scented products, almost half of them. Air fresheners and deodorizers, again, almost 2/3 of them react to these things. And more than half of them react to scented laundry products coming from a dryer vent. 74% of the reactions are considered disabling, and almost 60% of these people lost work days or a job in the past year because of exposure to fragrance products in the workplace. What is surprising is that autistic adults are more likely to experience reactions to chemicals and in a worse manner than asthmatics. Look at these statistics. 84% compared to 64% of autistic adults have adverse reactions from fragrances. They have more asthma attacks. They're more likely to experience effects from someone else wearing a fragrance product, or air fresheners and deodorizers in a room, or scented laundry products from a dryer vent than asthmatics. And they're more likely to find these reactions disabling. They have lost more work days or jobs in the past year due to the exposure of fragrances than asthmatics. The argument continues between those who practice environmental medicine and those who think that chemical sensitivities is a psychiatric condition because there's no literature to support that it is actually biological. And both sides quote the literature and cite the literature to try and support their argument while criticizing the other side. So how do we grade the evidence in order to understand whether or not chemical sensitivities is a true biological phenomenon? And the answer lies in this pyramid. Expert opinions are at the bottom. And at the very top are reviews of the literature called systematic reviews. The systematic review is the strongest evidence in support of an opinion, whatever it may be. A systematic review is a method for answering specific research questions, and it's more than just a regular review of the literature. It uses a predefined multi-step process to identify, select, critically assess, and synthesize the evidence from scientific studies. You need to do this in order to reach a proper conclusion. The system of going through all these steps needs to be transparent. We need to understand the reasoning behind each decision made in the choices and selections and opinions of each particular paper, and it requires more than one person to make the systematic review valid. There have been 3 systematic literature reviews published on MCS. One was done in 2006 by Desmunshi. I have reviewed this systematic review in the past. He looked at the provocation studies. In other words, he looked at the studies that either tried to prove or disprove that people with MCS could actually detect and react to chemicals upon exposure in an objective, blinded fashion. The other 2 were published last year. So let's look at them and see what we have. In the systematic review of 34 chemical challenge studies published in 2006, 21 of these studies were probably no good, based on the fact that, to the author, the odors of the chemicals were probably apparent. 19 of those 21 papers reported a positive response to the provocation exposure, but they don't count because the patients were able to identify whether they were being exposed to a particular chemical or not. So all of these studies were dismissed. There were 3 studies in which the patients were tested using nose clips or face masks, and these studies confirmed objectively a response to chemical exposures compared to sham exposures. But the author dismissed these studies because the MCS patients could identify the chemicals. How? Their eyes weren't protected and their eyes burnt. Only the chemically sensitive patients had eye burning, but those studies were dismissed as well. There were 7 studies where chemicals were used well below the odor threshold. And so it can be argued that maybe nobody would react to those chemicals at that level, but nevertheless, 6 of those studies failed to show a consistent response. 3 studies used olfactory masking agents. In other words, they used another chemical to mask the odor of the first chemical. And none of these studies found associations between the provocation and any kind of response. So they concluded that multiple chemical sensitivities doesn't exist based on this kind of reasoning. However, you may recall that we have identified 17 studies using capsaicin, that product in hot peppers, that demonstrated hypersensitivity of receptors that sense chemicals in MCS patients compared to controls. At the time of this systematic review, there were 7 studies already published, and they were excluded because, according to the author, capsaicin inhalation is not a classic stimulus described by subjects with MCS. Capsaicin stimulates receptors sensitive to chemicals, but these studies were not included in the systematic review. This systematic review, which was published just last year, looked for new diagnostic and epidemiological evidence for multiple chemical sensitivities. Once again, they found a predominance of females, and of interest is the fact that the patients were more likely to come from medium or high social and cultural areas of society. There were certain variations in genetics with respect to detoxification, but it wasn't clear if the genetic variations were due to the structure of the genes or actually a mutation affecting function. There are many papers which showed oxidative stress and neurogenic inflammation and hyperreactivity to stimuli, which they were able to detect with accurate brain imaging techniques. And the hyperactivation was of an area called the amygdala, which is part of the limbic system and responsible for fear and avoidance behavior. And of course, the olfactory cortex, the part of the brain which discerns what something smells like, whether it's a positive experience, a negative experience, etc. However, this hyperreactivity was not counterbalanced by activation in certain areas of the brain which are responsible for toning down the message. So instead of getting used to an odor, patients with MCS tend to show sensitization. This same systematic review also showed changes in heart rate and respiratory rate, concentration and memory, as well as changes in certain areas responsible for emotion that made these authors conclude that MCS may be an emotional disorder. The conclusion from the author of this systematic review was that the conclusions of the studies are uncertain and controversial, but they did note that there's greater activity in the limbic system and the autonomic nervous system in patients with MCS when compared to controls. The authors also reviewed the chemical challenge studies and again noted greater involvement of limbic system and autonomic nervous systems in the brain and concluded that the results are still uncertain and controversial. The limbic system is the part of the brain which processes sensory information, including odors, and the autonomic nervous system is the system that controls things such as heart rate and blood pressure and responds to stress, etc. What's notable is that the authors mentioned the capsaicin inhalation challenge tests and studies and then excluded them without explanation. They then concluded that it's not possible yet to diagnose chemical sensitivities with absolute certainty. And we have to agree based on the fact that there are no objective biological markers clinically. They stated it's difficult to assess the weight of the psychological component compared with the physiological one in the office, and it's true. And as a result, patients may feel unfairly labeled as mentally ill. A letter was sent to the editor in response to that published systematic review, and the author stated, I would expect the author's more critical position on the use of provocation tests. Many of them were performed in a very poor study design, which was not discussed in the paper. But as you've heard earlier in this webinar, we reviewed the systematic review of provocation tests, pointing out the difficulty in performing these tests in the first place. This author then wrote, they wrote about suspicion of intoxication. I think this author meant to use the word toxic. It's not the case with MCS. MCS is not intoxication, toxic. It's an overwhelmed hypersensitivity of sensor receptors with insidious chronic inflammation and oxidative stress. And when you look at this, you'll note that the 17 papers which were missing in this review that show an abnormal hypersensitivity of receptors when tested or challenged with capsaicin is proof for hypersensitivity. And then the author asks, aren't these statements sufficient to draw a conclusion about the somatic nature of MCS? In other words, why didn't the author of that systematic review make a stronger opinion in support of the fact that MCS is a biological phenomenon, somatic, not psychiatric? And in response to that letter to the editor, the author of the systematic review wrote back, our intention was to aid the prevention, the correct diagnosis, the recognition, and the care of MCS in favor of the wellness of the person. And they intended it in physical, mental, social, and working terms. Sounds good. We therefore hope that a proper diagnosis that links work exposures and MCS in a clear relationship of cause and effect will help patients to request compensation. So in other words, when pushed with criticism, they came out in support. A second systematic review was published at the end of 2018. It included 34 studies. And the author found that the main symptom trigger is stimulation of smell, which is mediated by the olfactory nerve, but also by the sensory nerve called the trigeminal nerve, which senses the irritation of those chemicals. And as a result, it releases inflammatory mediators. So the authors stated that research focus has shifted now from chemical stimulation, in other words, challenging patients with a chemical odor to see if you can provoke symptoms, more towards analysis of objective measures of brain response, the nervous system connections, and changes in cognition. And they found that the metabolism of the brain, when stimulated by odors, is different both at the cortex and at lower levels of the brain. And that this processing of odors is different in MCS. The neuropsychological state, stress, anxiety, etc., may possibly induce a predisposition. Sure, it can set you up to develop MCS, but it's not the cause. The authors also concluded that it tends to progressively promote the neurobiological processes of MCS. In other words, if you do have stress or psychiatric issues, not only does it predispose you to develop MCS, it makes it worse. So what these authors concluded was that there's an attention bias, which means that patients with MCS focus more on odors. One interpretation of this is that it's psychiatric. And the other interpretation of this is, of course, it causes patients to pay more attention to odors because the patient's experience is that the odors make them sick. They showed evidence of sensitization. The studies also showed evidence of limbic kindling. The limbic system is turned on. It's more easy to stimulate a response. And at a subclinical level, in other words, things that you cannot feel, they're able to find with appropriate scanning alterations along sensory pathways. The bias of attention and sensitization are related processes, and they guide us away from the exposures because they're perceived as hazardous. This very recently published paper is called Chemical Intolerance, a Puzzling Condition. How puzzling is MCS? Well, the authors state that opinions are quite divided about the cause and the mechanism of multiple chemical sensitivities. Those who believe that it's a toxic mechanism are criticized by toxicologists who state it's not related to the dose, The dose makes the poison. There's no dose-response relationship, which we reviewed earlier. Therefore, it's not toxic. The chemicals that these people are exposed to are not at levels which are considered to be toxic. Well, is it biological? Those who believe it's biological point to studies showing sensitization. They also point to the studies showing an abnormal processing of odors and abnormalities in genetics for detoxification. But there are others that state that this is a psychological condition, that the reason patients react is emotional and fear, and not actually related to a true reaction to the chemicals. Then the author states that chemical sensitivity is best conceptualized if you look at multiple factors working all together. So they incorporate the neurological, the immunological, the hormones, the behavior, all of these factors together with environmental factors, and it gives us a better understanding of multiple chemical sensitivities. But again, the chemical receptor sensitization studies using capsaicin were not reviewed in this paper either. So why is MCS still controversial and puzzling? Well, people still state there's no agreed upon case criteria for diagnosis or definition. That doesn't mean it doesn't exist, but you can argue as to whether the studies looking at it correctly captured the right subjects. No physiological evidence for sensitivity. Well, there's no physiological evidence if you refuse to look at the 17 studies on capsaicin challenge, but there's also evidence for genetic differences, and there is definitely differences with respect to olfactory function when we look at it via brain scans. It's not consistent with the known toxicology paradigm. Time for that paradigm to change. It's not always just dose related, and there's multiple studies showing that low dose exposures to chemicals that are not toxic can lead to chronic disease down the road. There's an association with psychiatric illness. Association does not mean cause. So why is MCS still controversial and puzzling? Well, some of the authors use old science. They use their own biases in selecting the literature that they want to use to support their opinion, and then they interpret what is available through a very biased lens. So what's not new about multiple chemical sensitivities? First of all, there is still a lack of recognition that MCS is a distinct biological illness, despite the fact that the literature says otherwise. There's a denial of workers' compensation claims, a denial by third-party insurance for disability and personal injury. Patients with MCS continue to fight for accommodation in the workplace, and there is a lack of medical education. This in particular creates barriers to access to health care. While in Canada, many hospitals, which are teaching hospitals and associated with medical schools, do promote scent-free policies, they are frequently not followed by the healthcare staff, therefore risking exposure to chemicals with MCS when they do try and access healthcare. Patients who do present with MCS are mismanaged. There are inappropriate treatment recommendations. Patients are told that MCS is not real, that the assumption that chemical pollutants are provoking symptoms is, quotes, in your head. For more than 25 years, it has been claimed that multiple chemical sensitivities does not exist as a biological illness, and therefore it must be a psychiatric condition. The evidence in support of psychiatric treatment for MCS is severely limited. In the past 25 years, most of the papers published have been opinions only. Actual studies of psychotherapy or medications are scarce. They're of low significance and mostly anecdotal. There are 5 case reports showing success using cognitive behavioral therapy. A case report is a description of a single case. 5 single case reports in 25 years. 3 single case reports using psychopharmaceutical medications such as anti-anxiety and antidepressant medications. There are no controlled trials which have demonstrated any efficacy specifically for patients with MCS by using psychotherapy or psychotherapeutic medications. None. Recently, eye movement desensitization and reprocessing, EMDR, has been advertised on the internet as a potentially helpful treatment. However, there is absolutely no evidence published regarding the use of EMDR for MCS. And it is important to note because there are some medical centers which are suggesting and recommending the use of this treatment, even though there is no published benefit. Why don't we ask the patients what they think? When we do, what we find is that psychotherapy to help cope with the condition and the impact it has had on one's life can be helpful. But psychotherapy as a treatment or a cure does not provide any help, but according to the patient surveys, doesn't really harm. However, the Task Force for Environmental Health identified that there is a stigmatization associated with being told that the condition that one is experiencing when one has MCS is in their head, is a psychiatric condition, and it is very frustrating as well. Anti-anxiety and antidepressant medications actually worsen symptoms because they aren't likely to help, but they're more likely to cause side effects, especially in this patient population who are sensitive to chemicals to begin with. What the patients report is that living in a chemically free living space is the most beneficial, followed by avoiding chemical exposures. Recently, attempts have been made to use mindfulness medication in patients with MCS, but what the literature shows is that it helps improve quality of life, but really does not change the overall illness status. I hope I've been able to shed some light on what we know about multiple chemical sensitivities, and that those of you who have multiple chemical sensitivities will feel that your future is a little bit brighter. Thank you for attending this webinar.